Welcome to the Davies Use Case webinar being presented by Children Nationals on improving documentation through an electronic health record initiative. This is a Davies Award winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. It is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving inpatient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It is my pleasure to welcome our two speakers today, Dr. Denise Bramble, and who is the Chief Medical Officer and Executive Vice President of Ambulatory and Community Health Services. In this role, she leads the tri-state clinical operations of Children's National Health System, primary and specialty sites, including regional outpatient centers, emergency departments, community health centers, pediatric practices, school-based health centers, mobile medical units, as well as nursing services in D.C. public schools and public charter schools. She also oversees the telemedicine program and the Children's National Network. Dr. Bramble has direct responsibility for more than 1,000 physician, nurses, administrative staff members, and oversees a budget of approximately $113 million. We also have Alec King. He is the Executive Vice President and Chief Financial Officer at Children's National. Alec oversees financial operations of the over $1 billion health system, $1 billion health system, with a direct responsibility for fiscal policy, performance goals, and health system planning. In addition, he works closely with clinical leaders to ensure they have the capital to meet the needs of their patients and research enterprise. With more than 14 years of experience in financial management, Alex brings a wealth of knowledge in hospital operations, peer relations, and business development needed to navigate the increasingly competitive healthcare market. And I welcome both of you to this webinar today, and I will turn the presentation over to you. Thank you for joining us.
Thank you for that introduction. As mentioned, this is Alec King, Chief Financial Officer here. If we get started, and I'll speak briefly before handing it over to Dr. Bramble. If you can advance the slide. So we're going to start out with kind of what is the local problem or proposed solution that we were seeking to address with the ambulatory medical record and the employer implementation that we'll be discussing today. So specifically, we were a paper-based specialty clinic with a lot of inefficiencies, cost barriers, falling short of optimization. These barriers included financial barriers. These included real patient access issues. So right here on the first slide, you can identify that specialist notes were not available. One second, let me move that. Sometimes in excess of 24 hours after the specialty visit, which causes a lot of challenges here. I'll jump to the bottom and tell you the quote from our emergency physician when discussing. It said, "How can I provide great care for this child when I cannot even see what happened earlier today in the cardiology clinic?" So with more than a 24-hour turnaround in terms of sending the records out for transcription, getting that record back in, a lot of care had been delivered between the time of the visit and when the transcription was available. In addition to that, financially, this transcription services added $1.6 million a year going externally to our transcription vendor. Providers and families had limited access to this information, and obviously there's some health safety concerns with the delay in getting that information to to the clinical decision makers. 246,000 transactions per year was our baseline for FY15. As I said earlier, total cost was actually closer to $1.7 million when you factor in the 1.6 FTEs, full-time employees that were dedicated to the logistics around transcription services, just getting the data in the right hands at the right time, in addition to the $1.6 million payment for the services. Like as I said, routinely exceeding 24-hour turnaround before the information was available. Once we sent the information out, it typically took 10.4 hours before we got it even back in. So the logistics around getting it out, and then of course then post getting it back in, getting it updated on the record. Total process time over 24 hours, and 10.4 of those hours are now waiting for transcription to occur. Goals for the project was the information had to be legible, had to be organized, had to be used to improve our integrated alerts. We had some regulatory and compliance risks associated with the transcription, kind of error rates, and also this amount of time that it was missing. Last two bullets there in bold: reliance on transcription, minimized, and cost reduced. That was the goal. Was to get rid of this transcription service with a better solution, but it had to be one that was supported both regulatory compliance and great patient care. Scope of the initiative: this wasn't all going to happen within the walls of the hospital. We had 450 specialty providers across 40 specialties. We have 7 regional outpatient centers covering a 30-mile radius. We have 17 hospital clinics here, 15 what we call pebbles, so kind of small single specialty sites outside of the walls of the hospital. This has led us to a 5-wave, 8-month implementation of Go Live. So that was the approach to the project. Governance and design, you can see in the following section, how do we govern it? We followed the governance path that's existing and established for our IT-related initiatives. So the top 3 committees you see: Leadership Council, Bayer Institute Steering Committee, which is our joint partnership between us and Cerner, as well as our CNH what we call Strategic Ops Committee. Those are standing committees with all major implementation, Go Live, and IS initiatives report to. Below that, we have an Ambulatory Operations Council. This is cross-sectional. This has physicians, this has nurses, this has financial people, IS people. This is a cross-organization advisory council focused on ambulatory services. And then at the connected into the Bayer Institution Operations Committee, which is very IT-centric and heavy, and timeline, roadmap, implementation, making sure that common resources are integrated and planned for. Below that, you see the specific, project-specific committees, the subject matter experts, all the kind of non-provider nursing operations subject matter experts, the governance committee over any ambulatory changes, and an ad hoc committee specific to this. So this is where you see the cross-functional view of the organization with all interests aligned to make sure to ensure a successful implementation of our solution. Next slide. I'm going to hand it over to Dr. Cora Bramble to walk through some process steps. Thank you.
All right, so this slide shows the complex process that we had in place prior to implementing the electronic health record and the process that took dictation out of the mix. So it's multiple steps. I'm not going to go through all of it, but it started out with the provider actually dialing the phone, going on into dictating it, and the note had to be transcribed. Then the documents had to be reviewed. If there were changes that took it, it made it such that there were several extra steps. And lastly, after the note was reviewed and approved, then the note would be available for other team members to view. And this whole process could take several days. So on the next slide, it basically gives us a snapshot of how this process is substantially streamlined using the current system, where the provider basically logs on to the system, They select the patient from the list. They actually begin speaking. When the note is complete, they can click sign. They log out of the system. And once it's signed, the note is immediately available for all the users. So we have an old process that included multiple steps to one that is much more streamlined that only includes approximately 6 steps. Next slide. So the implementation strategy from our perspective, it involved close collaboration between the Bayer Institute and the Children's National Team using lean approaches. We actually looked at the people, the process, and the technology, and looked at places where we could improve in the workflow and the staffing. So we were not trying to hardwire areas of our current processes that were not where they needed to be. There was significant engagement from multiple teams in terms of the design and the testing, and there was substantial go-live support. There were certain technology improvements that we had to implement, such as, tap-and-go access, some as it relates to new devices, and there was also a process that involved significant clinician training in terms of both the use of the electronic health record and voice recognition. We went live through 5 different waves from July 2015 to February of 2016. It involved, as previously stated, 450 providers, 43 locations. We increased our staffing to support the specialty clinics. And lastly, there was a visit reduction that was proactive and intentional over a 4-week period with each of the waves. So we decreased the number of patients that were scheduled so that until the providers were able to fully use the electronic health record and be facile with it. It involved 50 to 33, 25% reduction over a 4-week period. Next slide. So specifically in terms of how information technology was used, going on to the next slide, please. So there were certain solutions within the ambulatory electronic health record initiative that were instrumental in terms of the process. So having the EHR specifically with voice recognition. There were other areas in terms of technology that were important. E-prescribe, quick orders, the ambulatory organizer. We actually have a scheduling and registration system that is fully integrated and is a Cerner system. We have capabilities in terms of meaningful use reporting. And then we improved certain areas to actually make sure that the performance was optimal, such as tap and go. Next, please. This particular slide gives a visual, a screenshot of the dynamic documentation and what it looks like in the electronic health record. Next. So what was the value that we derived? I'll go through a few of these so that it's clear in terms of what did we gain out of all of this. Next. From my perspective as a chief medical officer, what's most important has to do with the quality of care. And when we have providers that are working out of multiple clinics, multiple locations in this, it is critically important that the notes are immediately visible for all the clinicians and that the discharge material is legible and organized. It improved the documentation compliance, and then the notes are searchable. So there's structured data elements so that the clinicians are able to see all the reference to a specific disease process or treatment. So in terms of quality of care, these specific components are critically important to me. Next. If we look at the number of ambulatory transcriptions prior to going live, it hovered around 70,000. And over the period of time where we went live with electronic health records, starting in Wave 1 in June of 2015, and then all the way through the five waves, what we see is a dramatic decrease in the number of transcriptions. So right now it's hovering under 10,000 and has been that way, and so it's a significant decrease from 70,000 to under 10,000. Next slide. Importantly, there was a significant and associated decrease in the transcription cost. So we started out with the cost being over $300,000, and you see a gradual decrease as we went live with the various waves. And right now, it is under $50,000. So not only did we improve from a quality of care perspective, but from a financial perspective, it also had significant return on investment. Next. So if we look at the post-implementation evaluation, these are the specific data. The actual volume of transcription with our baseline, we started out at 246,027, and the results in FY17 are at 18,728. That is an impressive 93.4% reduction. Likewise, the annual transcription expense decreased from approximately $1.7 million and it's hovering around $105,000. Again, that is approximately 94% reduction. The note availability, it went from 24 to 72 hours to notes being available immediately, and the actual process involved in transcription was approximately 10.4 hours, and that has been eliminated altogether, so the reduction is quite significant for both of those. Next slide. So what were the keys to successful adoption? How did we engage the physicians in this process? So we really had to market the value of all of this to the physicians that engage in. The fact that the notes were immediately available to other care providers, that there was less time required to create a note than if they went through the transcription process. The fact that there's structured data that can be pulled into notes, discharge documentation, and patient education materials, and that the product was relatively easy to use and it required little training. So these were the ways in which we really highlighted the value of this new system to the physicians. Next. So if we're looking forward in terms of future advancements, what do we have in terms of how do we anticipate the next steps? So next slide. So we want to improve the adoption and improve the return on investment even further. So there are certain notes that are not fully automated yet, the operative notes specifically, and there's an opportunity then to decrease the cost of transcription and the remaining around approximately 10% of the dictated notes. We want to look at the system. We actually have looked at the system to identify the non-users. And we want to really schedule one-on-one targeted session for these non-users and monitor the reports for increased adoption. There is another opportunity to enhance the performance, and that is using a cloud-based voice recognition system that will give us better performance, as mentioned, better accuracy and availability. And then we're looking at the mobile voice recognition tools for continued advancement. Next. So this has been our journey. Overall, we felt that there was significant improvement and significant ROI from both a quality perspective and a cost perspective. And importantly, it brought two teams from the IT perspective with the Bayer Institute and the clinicians and other staff to really make this a successful initiative.
Well, thank you both. Thank you, Dr. Cora Bramwell and Alex, for that great presentation. Just want to briefly inform everyone where to go find other Davies use case webinars, and that information can be found on the HIMSS.org/Davies, where you can find information on how to apply for a Davies Award and find how to replicate these processes. So thank you very much for the great presentation.